Good morning, everyone, and it's a privilege to be here today. So, this is the first edition of Special Interest Group meeting on autoimmune hepatitis, and this thought was conceptualized last year when we were analyzing our data on autoimmune liver disease. And we found that over the last decade, there's been an increase in the incidence and prevalence of autoimmune liver disease, and especially those acute cases of autoimmune liver disease, which we've started picking up, whether it's because of better diagnostic facilities or the suspicion has increased and we are diagnosing more and more patients. But then post-COVID, there's been a little surge in this phenomena of autoimmunity and could be related or unrelated to COVID. But then, yes, we are picking up more and more cases. The prevalence of other autoimmune diseases like rheumatoid arthritis, IBD, SLE, etc. has also gone up. And so is the case with autoimmune liver disease. And the whole thought came to us that since now this is not a kind of rare disease and we are seeing more and more cases, we need to have a task force on this, and we need to work on this disease now, because I think each center is seeing more and more patients with autoimmune liver disease. We are in the process of making registry data on autoimmune liver disease, and we've called it Indian Consortium of Autoimmune Liver Disease. And at present, we've taken ethical approval for 10 centers in India. And we're going to take all the data from them, analyze and see what is the spectrum and how these patients are being managed. And we plan to do further studies on this. And we also plan to enroll many more centers from India. So we would request all of you who all are interested in joining this group, they can get in touch with us. So the whole idea is to have an online registry over a period of time, but we are just awaiting some funding from ICM or some other agency. And if INAZL gives us some funding, that would really be appreciated. So the format of this meeting is going to be like, we are going to start with a case discussion first, and we have esteemed panelists and chairpersons with us. I think we can have the panelists on the stage and chairpersons can be there only. So we have with us Dr. Praveen Sharma, Dr. Baldev Rana, Dr. Binoy, Dr. Amesh and Dr. Sojan. They can be on the stage. And we also have experts with us. Professor Dhiman could not make it. Dr. Ajay Jain, Dr. Sunil Taneja, Dr. Varghese Thomas and Dr. Shalimar can give the expert comments. And at the end of this session, we will have 2 free papers which will be presented, and then 10 minutes for this SIG and task force activities which we can have in the next year. So with this, I think I can start with the case first. Okay, so it's going to be 20 minutes of discussion in this case. I'll quickly take you through this case, and then we can have comments from the panelists and finally expert comments from the chairpersons. This patient was 28-year-old female and a resident of Ludhiana, presented with jaundice of 2 months history. This is a real-life situation. The management of this patient might not be as per the guidelines or what are the recommendations, but this is what actually happened in this case. So I would please excuse me if this, it's not as per the guidelines. So she presented to us with jaundice of 2 months, and this was associated with high colored urine, no cholestatic symptoms, no fever, pain, abdomen, weight loss, and there was no history to suggest GI bleed, HE, or ascites, and no comorbidities in the past, no addictions. Now, let's just look at the investigations. The baseline hemoglobin was 15, platelets were preserved. Baseline bilirubin was 12, and it jumped to 18.9 in 4 days. AST, ALT more than 10 times the upper limit of normal. Gamma GT was 121, albumin was 3.8, globulins 3.9, and creat was normal. So she was initially evaluated outside in a hospital where they did all the viral markers. They were negative. Autoimmune markers were negative, the conventional markers which we routinely do. The only clue to the diagnosis was that the IgG was elevated, ceruloplasmin and iron studies were normal, TTG was negative. Now, the ultrasound was suggestive of cirrhosis. What we have seen in our setup, that around 50% of patients with autoimmune liver disease do present with cirrhosis at presentation. And this patient also had ascites. These findings were confirmed on an MRI also. And The provisional diagnosis in this patient was acute and chronic liver failure with a MELD of 30, ARC of 9 score. This patient was started on Plex outside, not given immunosuppression, started straight away on Plex. And there was no improvement in liver functions and coagulation after 3 sessions of Plex. Bilirubin went up to 24, INR was 2.5, and then this patient was referred to us. At our institute, the baseline investigations showed a bilirubin of 29, AST, LT were elevated, INR was 2.5. We also did the autoimmune markers, the conventional ANA, asthma, LKM, and AMA, all were negative. IgG came out to be elevated. Now, we tried to do transjugular liver biopsies, but we couldn't get access to that. So we thought that let's continue with the Plex and see the response to Plex. So let me start with the panelist. Dr. Praveen, what would be your approach in this patient?
See, this is a very common scenario. Most of us see this type of patient in our maybe ICU setting or in the OPD setting. But there are certain things which are slightly odd. This patient has no history in the past of any autoimmune disease, first thing. Second, when she presented to some other hospital, if you see by the platelet count, which is about 2 lakh plus, if you see the albumin, which is 3.8 or 3.8, and patient has got an ascites. So these are the things which, initially suspicious, make it possible that the patient has a long-standing cirrhotic disease or not. But based on your ultrasound, based on your MRs, finding it looks like the rate of hypertrophy there and other things are there. So still I will keep the possibility, though the only thing which is increase is IgG, which is very non-specific marker for any liver disease. It could be raised in autoimmune also, it could be raised in any cirrhosis. All autoimmune markers are negative, but autoimmune markers may be negative in patients who are presented with ACLF-like of features, and they may be negative, because in about 30% they are negative. So I will keep 2 possibilities. Autoimmune is first because you have ruled out most of the things. I will also keep Budd-Chiari as a possibility in this patient, because you are not able to do the transjugular liver biopsy, maybe because you are not able to enter into the hepatic vein. So my possibility will be a Budd-Chiari. I would like to do a Doppler first, maybe possible CT angio, and I will try to continue the Plex because there is no other option. If patient has not got any transplant option, then I think Plex is the only thing.
Dr. Baldev, what would be your approach in such a patient?
I agree with the Dr. Praveen. He has rightly pointed out about the platelet count, but the diagnosis we have definite evidence of a cirrhosis in this patient. So the IgG can be raised. It can be found in AIT-ACLF around 90%, which is the marker which is present in most of the patients with the AIT-ACLF. And 50% patients, they have the markers negative. So this possibility of autoimmune related ACLF is in this patient.
So Dr. Binoy, do you do Plex in your center, and how many patients are subjected to Plex?
Yeah, we do Plex, but not many. Mostly in the setting of ACLF or in certain cases of ALF. In the center where I am working, we don't have any transplant facilities. So generally, such cases will be shifted to a higher center.
So I think the common scenario is that Plex will not be available in most of the centers, and such sick patients should be referred or usually referred to a high center for management. So as this patient was referred to us, and we thought that, okay.
Can I just make a?
Yeah, please.
Would you consider Wilson's disease here?
Yeah.
Young lady, because only ceruloplasmin has been done.
Yes.
KFring is not checked 24 hours.
Yes. So the workup for autoimmune, this Wilson disease was negative, and hepatic veins were normal on Dr. ultrasound. So.
There is because we do not have much options most of the time, then we consider that maybe the Plex is the only option, let us go with the Plex. But sometimes we see that Plex is a dual side sort. People, if this patient has come to me, probably I will have waited slightly more to see what is the natural course. It may be possible that most of these patients, they recover because patient has got a good albumin, patient has got a good platelet. Then I think if you wait and watch for a period of time, if we do not have an etiology, I think sometimes it also helps the patient. So if the patient is deteriorating, there is no other option left, then we do whatever we are with that.
So since the patient was not improved, we thought we'll continue with the Plex session, gave her 5 sessions of Plex, and let's see what happened. At the end of 5 sessions, bilirubin came down to 10, INR also improved, and we explained the patient the prospects for OLT. She didn't have it. Now, the dilemma was whether to start steroids or just wait, and since this was an ACLF-like presentation, obviously the prognosis in ACLF is not very good. But in spite of that, we took the decision without a biopsy, we started this patient on low-dose steroids, and at 7 days, the patient presented again back to us with worsening jaundice and worsening of ascites. Now, again, the bilirubin shot up to 25, and this INR was 2.6. The ascites had increased. Cytic fluid analysis showed high SAG ascites, and there was no SPP. So, what should be the next plan, Dr. Ramesh, in such a patient? Now, Plex has kind of failed in this patient. We gave low dose of immunosuppression, that is not working. So, what do we do from here?
Good morning, everybody. Two issues here. One, we have started steroids without a biopsy. Second, initial improvement and subsequent worsening. So we are in a confused state. What to do? I think at this moment, we have to get a liver biopsy. Without that, it's very difficult to move forward. As other alternative diagnosis is not ruled out totally, and we are still considering this as autoimmune. With a liver biopsy only, probably we can make the diagnosis at this point of time.
So, Dr. Sarjan, how would you do liver biopsy in such a patient? Now, the transjugular route has failed twice, and INR is 2.6. She has now moderate ascites. What do we do?
One option in this case would be to go for a thromboelastogram, correct the necessary steps, and go for a plaque liver biopsy. But either but before going that, I think like we should still go for a second attempt at transjugular liver biopsy again to see whether it is possible or not. We don't have any experience with lab-controlled biopsy, but I think like a correction of the coagulation parameters and biopsy would be a way if TGLB fails again.
So, I think biopsy decision is always difficult. Yeah, Dr. Shalimar, please. So, no, yeah.
Bilirubin likely related to the infection. You've given him steroids, bacterial, fungal needs to be looked at. Two is the patient has moderate ascites. Doing a plug biopsy would be associated, even any kind of percutaneous biopsy, this will be catastrophic. You won't be able to, the radiologist will not be willing to do biopsy percutaneously. Transjugular, yes, can be attempted. If you've taken the right side, you can take the left side.
So, we took it twice, and both the times we failed, yes. Right and left, yes. Yes, we couldn't do that.
The radiologist can try transfemoral.
Transfemoral, yes. So, I think transfemoral can also be right. So,
I think, I know it not be a cautious thing, but sometimes event-guided biopsies also, you can do it. If in the first phase, if you're not able to do the transjugular, even if the patient has mild ascites and patient has got a coagulopathy, US-guided liver biopsy is also indicated. You can plug the track.
yeah. Dr. Varghese, your thoughts on this case?
Plug with a US.
What we do?
One thing is that the patient has a high bill. He is ACLF. So it's still US guided. You don't have clear-cut guidelines to do a biopsy.
Totally
Such
agree.
a sick patient, you may land up with more complications because this patient bleeds is going to die without a transfer.
No, what happens when we do a US-guided biopsy? You take the pass and you keep the needle inside, and then you put a Doppler and see whether the Doppler track shows any color flow. If there is any color flow, then you have two options. Either you just push the biopsy back, and then most of the time it coagulates, it fills up that gap, and there is no bleeding further.
Dr. Varghese, you have so much of experience. Your thoughts?
I just wanted to use liver biopsy. Most of us will comment. The issue is when the milli is so high, cholestatic picture, it's very difficult to do biopsy. These patients have no chances of bleeding later. Do you have any experience?
Look, I'm not saying I am in favor of doing a US-guided biopsy in such a scenario, but if you do not have any option, if you are failing with the transjugular and we want a biopsy to be done, I think this option can be considered, irrespective of there is some associated risk.
So, diagnosis was not clear in this patient. The only clue to the diagnosis was elevated IgG. We were not sure. She was not responding to immunosuppression, not responding to Plex. So, what do we do from here?
See, we all want a liver biopsy, but technically it is going to be difficult because percutaneous liver biopsy, as you rightly suggested, such sort of expertise may not be with all the other people. So, in a patient with ascites, coagulation failure, even if you correct it, there could be subsequent using, and we may lose the patient. As Shalimar said, we actually do not know what is the insult. This is really, we don't know the first diagnosis, the background diagnosis. We don't know the insult which has happened. So, we are in a situation where we do not know either of this, okay, and then we are trying to treat. That's the issue. So, are we really dealing with an autoimmune disease? We are presumably. Second thing, what has caused the acute insult? Is it something which we are yet to find? Is there a history of drugs or CAM or something like that?
No CAM, sir.
No. Okay.
Yeah, Yeah, what has been her weight? Has she been an obese? Because was there any underlying C faction is there, and the A faction is only the trigger.
Yes, sir.
The trigger, you need not have any specific instances. Even a non-specific viral or anything can trigger this one. Personally, I don't have any other diagnosis other than the autoimmune hepatitis in this patient. We have seen quite a number of for this one. Whether there is any added obesity is there, I won't jump to, I am an old timer, so I won't jump to the plex in these patients. I will give them good amount of an albumin and then remove the fluid there, test the fluid there, and then try very careful steroids. It's done wonders in such people. And then what about other autoimmune markers?
Yes, sir.
Just one comment. Was not that steroid dose high enough in a patient who is already in a liver failure, 0.5 milligram per kilogram?
So usually it's high dose for ALF and ACLF group. It's 1 milligram per kg body weight. So we've given 0.5.
That's
0.5.
for patient which are not decompensated.
Yeah.
This patient is already decompensated. So here, even if you want to give, that's what we do. It's a very low dose of steroid just to suppress the innate immunity, not that high dose, because this was, and probably that has precipitated an infection and worsening of the jaundice. This is what I would believe.
So I think obviously there were a lot of issues.
Just add one point to it. Wilson's is another possible differential, which is always difficult to differentiate in a presentation like this of autoimmune hepatitis.
Yeah, agreed. So Wilson's is a close differential in this patient. But then we tried to mobilize the fluid in this patient and gave her diuretics and albumin. The next 10 days, we took that chance and we did a EUS-guided liver biopsy, as Dr. Praveen suggested. This is with a 22 gauge needle, and fortunately, we didn't have any complications, and biopsy was classically suggestive of autoimmune hepatitis. There were incomplete nodule formation also, which was suggestive of cirrhosis. Rich lymphoplasmacytic infiltrate, and interface activity was very high. So the diagnosis of autoimmune hepatitis was confirmed here. Now, what do we do from here? Dr. Praveen, your thoughts? We know that this is autoimmune hepatitis, not responding to plex, low dose steroid already given. What do we do?
So, ideally this patient should be listed for transplant. This is the ideal scenario. And because this patient has got a high MELD, I think the CTP score is also more than 10, and patient has probably not responded to steroids. So whatever secondary thing which is available to us, I think that is not going to work in this patient. If given a scenario, I think I will restart the plex, because that is the only hope, because bilirubin has started from 26 to 10. So that is only the option which I can think.
So Dr.
Immunosuppressive drugs in this scenario is, I don't think it's good.
Dr. Ramesh, what would you do?
Yeah, I do have similar opinion. Transplant option need to be discussed with the patient, and ideally patient should receive transplant advice. And if it's not there, then plex is another option. These are the two things. First of all, transplant need to be advised in this patient.
So we discussed transplant with this patient, and obviously there was no prospects. So we thought, let's continue with few more sessions of plex and low dose steroids, and let's see the response to that. After 5 sessions of plex, again bilirubin came down. There was some improvement in INR. We continued with the steroids. Subsequently, over the next 10 days, she came back again, worsening of liver functions, and INR also got prolonged. So this is the timeline of this patient. Baseline bilirubin was 18.9, went up to 29, came down after plex, again went up, came down. We did a biopsy here. 30 was this last reading, and then she had progressive worsening, multi-organ failure. The transplant prospect was explained, they didn't have it, and finally we lost this patient. So the whole idea here is to present a case. This is a clinical scenario which we commonly encounter, and sometimes we might be right and sometimes we might be wrong also. I think the ideal treatment would have been transplant for this patient, and we could not offer transplant to her, and finally this patient's come to the illness. So any thoughts on this case before we go on? So it's a standard volume plex we do. We don't do high volume plex, sir. 1.5. Yes, 1.5 to 2. Dr. Ashish, you have a lot of experience in plex. So any thoughts on plex in this patient? Yeah, please.
I just
Just wanted to know, are there any features on the biopsy which will tell you the patient will not respond to the standard therapy? Because normally in our patients with ALF and ACLF with AIH, massive necrosis, confluent necrosis, massive collapse,
Massive collapse.
that tells you that patient might not respond.
Yes.
So none of these patients.
This patient didn't have that massive collapse, yes. So the activity was very high in this, the interface activity and lymphoplasmacytic infiltrate, but some massive collapse was not seen in this patient. But in spite of that, this patient didn't respond.
Thanks, Sunil. I think we would have done most of the things what you have done, and it's unfortunate that patient didn't respond. Few patients with plasma exchange may not respond, and ACLF, even if we see the data, maybe around 15% increase in survival with Plex. We may not have pushed for liver biopsy because other than just confirming our hunch, it is putting a patient at too much of a risk. I would have opted for a second session of therapeutic plasma exchange without pushing for liver biopsy at that point of time, but went off well, and but I don't have anything more to add to what we have already done. Thank you.
So quickly, just a review of literature.
The steroid dose, what we use is a small dose. You have also used 0.5 mg per kg, not a very high dose. We usually will be treating with 20 milligram because of sepsis risk, and anyhow is a candidate for transplant and not for increased immunosuppression. So we would have to prefer 20, but I don't think that caused the harm.
So quickly, Dr. Praveen, prognosis in AIH-ACLF, you want to talk about it a little bit?
I think most of these patients, if they have some sort of organ failure, severe coagulopathy, severe ascites, transplant option is the best. And people have, there are a number of studies which have shown that if the MELD score is more than 24 or maybe 27, patient is CTB score more than 10, these are the patients, I think they will not respond to your steroids. So it's better to avoid steroids in such scenario because it complicates the picture. It only makes them not vulnerable to the liver transplant. So if you do not have any option, then
yeah. So this is meta-analysis we've done, and mortality is very high, 30% in ACLF, and poor prevalence is around 12% of ACLF in all the AIH which you see. Second point is option of treatment in AIH-ACLF. So we've discussed transplant. Second option is Plex, or do you want to give some other immunosuppression? Dr. Baldev, your thoughts?
I think there is a paucity of data on AIH-ACLF except for steroids. So there's a data on tuximab they use, but that is just garden variety or autoimmune hepatitis. So I'm not sure about the other immunosuppression, the role of other immunosuppression in the autoimmune.
Dr. Binoy, predictors of response in AIH-ACLF, any suggestions on that?
There are some data from this ARC group where they said high age, high bilirubin, MELD more than 27, and liver biopsy which shows massive necrosis of fibrosis. They are all bad predictors.
Yeah, so this is this data from the ARC group, and which showed that advanced stage, severe liver disease, presence of HE and high fibrosis are poor predictors of response. And you have to identify the early predictors of response, and this is from, again, the ARC data. And they showed that if the ARC score is more, this MELD is high, and Surfasa score, if it is high, that means the response to treatment would be poor. And Plex we've discussed. As such, the literature on Plex in AIH-ACLF is very little. There's just case reports. Plex has been used in acute liver failure, but not as such in AIH. So these are just case reports, and they've shown some benefit. Some patients did improve, but then obviously there is a relapse after some time. And last is treatment in steroid non-responder. So this is one study which I could take out. This is 2011. They've given tacrolimus, and they've also combined MMF with Plex. There was some improvement. Out of 13 patients, 9 received second-line immunosuppression. 3 required emergency transplant in spite of that, and 1 died of sepsis. In spite of this, overall mortality was 31% as compared to 1.7 who responded. So this is one algorithm which has been suggested recently, that if you have acute AIH, INR less than 1.5, no HE, give prednisolone and wait for the response. The second is INR more than 1.5, no HE, then you can give oral or even IV steroids. We're talking about acute AIH, it's not ACLF presentation. And look at the response at 7 days. improvement, continue steroids. If there is no improvement, then you can think of listing them for transplant. And AIH, ALF, INR is more than 1.5 and HG, straight away list them for transplant. So there is no algorithm as such for AIH, ACLF. I think we need to work more on this and have some kind of algorithm to manage such patients. So I think I'm going to stop here and thank you all the panelists for this wonderful discussion.